I routinely begin by checking the patient's feet for pronation or a flattening. Most importantly, I look for the differences in their feet on and off weight bearing. You see, often, it's not how flat a foot is that's significant, but how much it flattens when you stand as opposed to sitting. Whether you drive a truck that sits high off the ground or a low sports car, if one person gets in it that's not overweight and it seems to bottom out, you have a suspension problem. Well, the same is true of your feet and your structure. I also see if the patient has a matched set of feet. That is, I observe whether one foot looks flatter or more rolled in than the other. Often, this is an indication of a longer leg and can have profound effects not only on the feet themselves, but on the knees, the hips, and low back. You know, even if you drive a Rolls-Royce, if you've got a 22-inch wheel on the front right and an 18 on the front left, you're just not going to get a very good ride, are you? While the patient is standing, it may be evident one hip or one shoulder is higher or lower than the other, or that they are leaning to one side. Observations are made to see if one knee is more flexed or bent, positioned more forward or turned more inward or outward than the other. Perhaps the patient may be standing with one foot more outward or inward than the other also. Often patients with a leg length problem stand more on the outside of one foot and on the inside of the other. I then do a gait analysis, which consists of watching them walk. Here many things become obvious. For example, as I mentioned, most people have tight calf muscles. I find this an often undiagnosed, yet very significant factor in those with arthritis, as well as in athletes at all levels. Patients with this condition have what I call an early heel-off. This means that because their calf muscles are tight, they have a tendency to walk more on their toes and their heels lift off the ground far more quickly. Often patients with this problem trip because their feet seem to get stuck on the ground, especially if they're wearing rubber-soled shoes and walking on carpet. Many older patients think this is simply age-related, or that they're just getting clumsy. But it is often tight calf muscles that are the culprit, preventing them from being able to lift their feet properly. I also see this same problem in children who are often told, pick your feet up when you walk, and are really totally unable to do so. If possible, a simple squat test is done. Patients are asked to very slowly squat barefooted. This remarkably simple test can really help identify many problems. Those with a longer leg, for example, will usually turn one knee inward and shake more than those with more equal leg lengths. Tight calf muscles will make it very difficult to squat fully without lifting your heels off the ground. And badly pronated or flattened feet will cause you to squat with both knees facing inward. After observing the patient stand, walk, and squat and other things, we then begin to check such things as leg length, joint motion, muscle strength, and other areas for flexibility. Although anything less than 1/4 of an inch is often thought to be an accepted, normal difference in leg lengths, I have found that at times, even small differences as this can have quite significant implications regarding joint pain as well as performance in athletes of all ages. I was privileged to assist the 2005 University of Georgia golf team. They won the NCCA National Championship and found the improvements I made quite helpful. With the results of our examination hopefully confirming and substantiating what I've observed initially, or perhaps giving us new insight, I reevaluate the patient. They are asked to stand and walk again. Then the squat test is repeated. This important test is now done with a lift placed under the shorter leg. Increased balance and alignment is usually immediately demonstrated. Sample foot inserts are then placed under the feet, and again this test is conducted. This is done much like trying on different combinations of prescription eyeglasses. Multiple corrections are tried until maximum improvement is seen. The more precise the corrections, the better the improvement. Patients, for example, who have knee pain are usually quite surprised to see the immediate reduction in their pain with these temporary corrections. In addition, we sometimes do video analysis to better study or demonstrate our findings. We use Dartfish, that's our preferred program, and it allows frame-for-frame comparisons and evaluations. Just as a good football coach learns from studying game films, slowing down the gait cycle and overlapping before and after treatment pictures can be an invaluable aid in better understanding problems in those with arthritis or sports issues. Another simple yet very informative part of our examination is a shoe evaluation. In the same way that a good tire expert can look at the tread on the tires of your car and determine if you are using the correct amount of pressure or if your wheels are out of alignment, and then tell you just about how your car is riding, Evaluating the wear pattern on your shoes can be very telling as well. As a matter of fact, nothing really tells a better story about how you're walking, running, or functioning than the soles of your shoes. A normal wear pattern occurs on the outsides of the heels and then the middle of the soles of your shoes. Those who pronate or roll in excessively will have more wear on the insides of the soles of their shoes. Patients with tight calf muscles will wear out the tips of their shoes more than other parts because they cannot easily pick their feet up. Individuals with this particular problem may also have holes in the tops of their canvas shoes, where their big toe has actually tried to force its way out of the shoe. This is because the toe contracts to compensate for a lack of motion at their ankles. It's also important to compare the differences of wear pattern on the soles of both shoes. You obviously want a good wear pattern, but you also want one that's equal from side to side. Leg differences are often a key factor in different wear patterns. Among other things, treatment may consist of individually prescribed stretching exercises, trigger point injections, shoe lifts, and fully custom foot inserts, all aimed at decreasing symptoms and improving joint function. Since we often use unique inserts, which I have designed, and because so many people use varying types of devices to support their feet, I am frequently asked just what it is that makes mine better and more effective. So let's take a moment and let me address this. Saying you have a foot insert can mean anything from a soft, flexible insole to a state-of-the-art, fully custom, handmade, precise device. And current terminology only serves to confuse us more. So whether they're called foot supports, custom foot inserts, orthotics, etc., foot devices vary as much as diamonds. And frankly, because there is no industry standard, you have no way of telling whether one particular device is made properly and whether it will be more effective than another. So unfortunately, although initially they may look alike, yes, just like those two diamonds, one may be almost worthless while the other priceless. But there are a few things you can think about when evaluating inserts. First, most people have feet that roll in or flatten to some degree. In these cases, having some sort of support under your arch certainly would be helpful. But remember, there's a very big difference in putting something under your arch for comfort like a foot insole and having something custom made, which is a true orthotic, specifically designed for you to optimally control abnormal function. Second, the word orthotic actually comes from the Greek and means straight, upright, and correct. So a true orthotic, by definition, should straighten you out to some extent or correct your abnormalities and not simply be something that cushions your foot and feels comfy. Next, even quality, fully custom orthotics vary greatly. But there are three things that make an orthotic good or optimally effective. The first is that because there is a difference in the positioning of the foot when you're sitting and when you're standing, it's critically important to capture the foot when you're sitting or lying down in its ideal position, not the position it's in when you stand and it collapses or changes. Even great devices made from a standing position cannot provide ideal correction. Why? Because they have captured the foot in its abnormal position instead of its ideal position. This is a very, very important concept. Second, the device has to be made of such a high standard of quality and workmanship so that it holds the ideal precise functioning position. And this quality must be evident in correction as well as longevity. And third, multiple visits have to be made to fine-tune the corrections, just like trying on corrective eyeglasses. Again, the more precisely this is done, the better you will perform and the fewer symptoms you should have. And the precise degree to which you are indeed straightened out is what is most critical. This is accomplished by combining what my examination reveals as well as by what the patient is comfortable with. Some people simply can't tolerate ideal correction. Another important thing to remember is that orthotics are not a cure-all. Not everyone needs a custom insert. That said, everyone does have mechanical problems to some extent, and ideally correcting them through whatever means is necessary will indeed be helpful in increasing performance in any sport and decreasing arthritic symptoms. It's also important to understand that inserts are only a part of the treatment. For example, many people have tight calf muscles, as we mentioned, or one leg longer than the other, or one foot that flattens. Simply making an insert is not the entire answer. Lastly, a good set of fully custom inserts are expensive. There's an awful lot of work that goes into creating exacting corrections. But let's face it, if they last for years and years to come and prevent a hip or knee replacement, what are they really worth? Besides, they may just improve your golf game. Remember, no sports performance evaluation or arthritic treatment can be complete without first considering and subsequently improving upon how you stand and walk.